major paper on mobile, on the idea that mobile itself was going to emerge as a global power all the way back in 2006. We released several papers on the issue of mobile affecting public education and other matters in 2007. One of those papers was co-authored by myself and Alec Ross, who's now a senior advisor to Secretary Clinton on the Internet Freedom agenda in the State Department, something that we helped incubate and birth here out of NDN. In 2008, Tom Khalil, whom many of you know, who's the Deputy Director at the OSTP in the White House, wrote a paper for us on how mobile was going to change global development, which had a big section on mHealth in it. And so we began in looking at and understanding that in the holy grail of healthcare reform, which is to improve outcomes and lower costs, which is what we're going to be fighting very hard for whatever happens with Obamacare in the Supreme Court. This is going to be the great challenge for us as a country over the next 5-10 years, is this emergence of classical technology innovation, now increasingly being funded by VCs and entrepreneurs, the people who have attacked many other problems in our lives and solved many problems, that we're seeing, I think, something of great promise and hope on the horizon for us, which is this idea that mobile, which is now universal, ubiquitous, and powerful, could be deployed to improve health outcomes and lower costs. How that happens, what the role of policy is in accelerating this, how we make sure that Washington is doing everything it can to nurture this incredibly exciting moment of the intersection of public health and technology, is something that I hope we can commit to here as playing a major role in the next few years, because we all know that no matter what happens with the Supreme Court decision and so-called Obamacare, that the challenges of improving health outcomes and lowering costs will be with us no matter what. And we simply don't have enough tools in our toolbox, really, in this country right now, to feel confident that we're going to be able to do this in a way that is consistent with our values and what we want to have happen in the American healthcare system in the next decade. So it's our hope that we're going to be committing to a series of events in the coming years, coming months, coming years, to really help foster this conversation and push it much more directly into the mainstream of the policy debate here in Washington. It's our belief that this is sort of the next great frontier post the ACA decision as we get into 2013 and beyond. So thank you so much for being here today. I left my little bios of everybody upstairs, so I'm not going to attempt to butcher it. But the bios are on their website. We promoted this relentlessly to all of you. And here's what we're going to do in terms of program. We're going to hear from Dr. Yael Harris, who's at HHS, who's going to give us an overview of what the government has been doing in both the information technology space, electronic healthcare records and other things, which there has been substantial and significant progress on in the last several years, and also some thoughts about government and mHealth. We're then going to hear from Dr. Cohen, who's a new friend who we've just met, who's here based in DC, who's leading a group of physicians to really rethink and look at many of the same issues that I just laid out, as in how do we take advantage of this mobile revolution to improve health outcomes and lower costs. He's going to be giving a presentation looking at it from some of the consumer and doctor point of view. And then David Ludvigsen from Genomics, who's based in the Bay Area, is going to take all this abstract conversation and turn it into something concrete. You're going to see an early prototype of technology that we hope will become standard and ubiquitous in the next 5 to 10 years that will give you some real sense of what's possible in this new world of mHealth. So thank you all for being here today. I want to turn it over to Dr. Harris. Thank you, and I really appreciate you taking the time to be with us.
Thank you. And I guess we don't have my slides up, so she's
No, we do.
Oh, okay, terrific. Thanks.
Popping them up right now.
Perfect.
Christian,
Great.
you? Okay.
Thanks so much. That is, thank you.
Thank you. A cool graphic, too.
And I think I'm live now. Well, thanks so much for coming, and just wanted to let you guys know. So I am with the Department of Health and Human Services for the federal government. At the start of the administration, I was with the office that's called the Office of the National Coordinator for Health IT, which is the office that runs electronic health, supports coordination across the government in terms of electronic health records. How many of you, by show of your hands, know what meaningful use is or have heard of it? No, look around. Most people haven't in the room. So I'm always surprised just because it's been everything I've lived, eaten, and breathed for the last so many years. A lot of the confusion around it, people think that it's part of the Affordable Care Act. It's not. This was started prior to the Affordable Care Act with the stimulus bill. So what this is this is an incentive program for providers, not just physicians. There's a whole definition that's standard by the Social Security Act for clinicians and for hospitals to get reimbursement for the use of electronic health records. But it sets the bar on what is an electronic health record. So it's not just buy a computer, plug it into the wall. You have to be using it in what we call a meaningful way. In other words, a way that we see as driving quality of care, better patient outcomes. And it's like an escalator in that the baseline, the first stage of it, start off relatively low. Now, I don't mean low in terms of anyone could do it. It's actually quite ambitious, but low relative to where we want to be eventually. And then every several years, it's going to keep rising, increasing. So we're just finishing stage 1, which, as I said, the bar was relatively low. Depends on who you are. If you're the White House, the bar was set way too low. If you are a provider, the bar was set way too high. And for those of you who don't know politics, it's a kind of a give and a take. And the argument was, if we set the bar way too high, no one's going to go for it. And the White House said, but we're incentivizing. We better be asking for something out of this. So there was a progression that I didn't include in these slides, but of starting where we want to be capturing data electronically, capturing clinical quality information, beginning the exchange of data, and then moving towards actually reporting outcomes in the next stage, and then finally showing improved outcomes. The next stage is in draft. Comments came already this summer, and the final rule should be out this fall. It will require secure portals, which will hopefully include patient information. I can't speak to the final rule, but that was what was proposed. So information where patients are getting engaged. The proposed for the next stage, which will be coming out around 2014, will be interactive health technology. So I am on what's called the Meaningful Use Work Group, a work group that informs a federal advisory committee, and I'm pushing strongly for the use of mobile health as part of that. So you won't see that in the next few years, but you will see that as we move forward with this, reaching out to the entire population of the United States, the same kind of push for this to be integrated with the records that your doctor and your provider keep. Next slide. Thank you. So this slide was actually developed by a colleague of mine from New Zealand who was a fellow in HHS for a year. And the reason I show this is because, for two reasons. First of all, the other nations of the world have been far more advanced than we have in mobile health. Since probably the mid-2000s, they've been using mobile health for outreach to rural, underserved communities, for public and population health. They've really been doing a lot of outreach. And the uptake here in America, as Dr. Rosenberg said, the NDN started looking at this in 2007 and was really ahead of the curve in terms of America. America didn't understand and see the value. There's no reasons for that. First of all, no other nation has pay per text message programs. We also have a fighting among wireless industries that doesn't exist in other nations. So there's a variety of different barriers that we have in America, but I think we've been seeing a real turn in the last couple of years towards mobile health. And this message really documents why. Mobile health is really, it's integrated daily life. It's always on the person. So unlike going back home to your computer, you have this in your pocket, and especially now with droids and with the iPad and other tablet screens, people have technology with them. How many of you have a cell phone on you right now? How many have more than one phone on you right now? See? Don't be embarrassed. We were joking about this yesterday in a meeting. Really, technology is ubiquitous now. It's in your pocket with internet, with texting, with having phone service. I mean, my phone actually broke. The speaker part of my phone broke, and my daughter's like, "Can I have your phone?" I'm like, "Well, it's not really a phone now." She didn't understand that without a phone service, it wasn't valuable because because to her, a phone means, I can check the internet and download YouTube videos when mom's not looking. So it's become a ubiquitous part of our life. It can also be personalized, which is really key in healthcare. The future of healthcare is about patient engagement. It's not about the burden being on the provider. It's about the patient being engaged in their healthcare and motivated to do a better job of managing their healthcare. And so having a phone that's personalized to meet their needs, whether it's sending a text message as a reminder of when you want to do your diabetes screening, or you eat breakfast at 7 a.m., so you send a reminder that 2 hours later you should take your pill. It's having it personalized to meet your needs when and where you need them. And then it's ongoing, and it's also social support. The military has really engaged in mobile health because of the need for PTSD management. It has transformed the way they manage people. When you think about the military, many of them are going back to communities that don't necessarily have a VA hospital right there, and yet they're suffering from severe trauma. Having this interactive telemental health capability through the phone has changed the way we're managing healthcare. And so really, phone is going to become the primary source of healthcare moving forward in the future. Not the way but using the features of the phone to help support healthcare. Now, here in America, I think people always think it's not being used. My agency actually focuses on the underserved, and I think that's why we are one of the first agencies to really take a forward stand on mobile health, because we're seeing the need to reach out into underserved inner city populations, rural populations, populations with multiple chronic diseases. And so we often think, well, the poor don't have phones. Homeless people don't have phones. Well, when you look at this, this was data that was produced in 2010 by PricewaterhouseCoopers. 80% of the Medicaid population actually has SMS, that's text messaging capability on their cell phone. 63% of those with no insurance have cell phone capability. And the latest data I just heard in 2012, I think this was in 2011 data, I don't apologize on the source, is that 50% of United States households now have a smartphone. So it's really moving beyond text messaging to actually having technology at your fingertips. Another thing I want to talk about is a program that's become ubiquitous. How many of you heard of the Text for Baby program? There's been tremendous outreach, a lot of support from the Obama administration on this. The federal government is part of this as a public-private partnership. And what that means is that it's a privately owned product, but we're working with them to help do outreach and education and also fund a national evaluation. This is a free text messaging program, as you can see. It's focused on parents and caregivers of young children up to the age of 1, including pregnant moms, available in both English and Spanish. And currently they have over 300,000 enrollees. The goal is to get to 1 million enrollees. Preliminary evaluation has shown that it's been highly effective in changing behaviors, whether it's putting babies to sleep on their back. One of their favorite things is, I think it's called 16 and Pregnant. I don't watch MTV, I apologize, not my demographic, but that's one of the most popular programs on MTV. Unsolicited, one of the mothers on that program was talking to a friend, and she's holding this tiny newborn, you know, I'm assuming it was a preemie, they didn't talk about it, and telling her friend who's very pregnant that this program that was great because it told her that after she feeds her baby, she should clean out the teeth so that it doesn't get cavities. Even though there's no teeth yet, just wipe the... And her friend was like, wow, that's great advice. How do I find out about this program? This is an example of how mobile health can really help. It's text-based, so it's not as interactive as it could be. Eventually, they're hoping to move that way. But it means it reaches the majority of the population, young moms who can only afford text messaging programs. It provides messages 3 times a week, personalized to their due date, so it can tell them, you know, about breastfeeding guidance. Once they give birth, they can give them resources for food and nutrition programs, postpartum counseling. It provides guidance, education about prenatal vitamins. At every stage of the pregnancy, there's information to help them move along. And it's provided free of charge, regardless of whether they have an unlimited text messaging plan or they pay per text. There's an agreement across the wireless industry to provide free text messaging. So it's a fascinating program. It's really revolutionized the way of reaching out to the public in general. And a number of programs have developed off of that, one of which the federal government is initiating, and I'll talk about it more. So just to give you guys... there we go. An idea, as I said, it's personalized to your due date. This is an example of one of the messages about getting prenatal care and how important it is. It talks about everything from prenatal care, such as diet and exercise and nutritional eating, to labor and delivery, safety, such as, for example, how many of you knew about the new car seat law? I have he just turned 4 and I didn't know it. Apparently, newborns through the age of 2 now are supposed to be rear-facing. Did not know that myself. If I'd been a Text for Baby client, I would have known. So it's been really revolutionary in terms of when there's been outbreaks of whooping cough, they could focus text messages to that area to inform parents to make sure they got the whooping cough vaccine. So it's really been revolutionary in providing public health messages, timely, relevant public health messages, as well as general public health messages. For example, breastfeeding, nutrition, immunization schedules, maternal health and safety, and pediatric milestones, such as if your baby is not holding its neck up now, you should contact your doctor. Around this age is when you should be seeing these signs. So really, guidance that parents, especially those who may be young or not have access to what to expect when you're expecting, which was my Bible throughout my pregnancy. Those of you who've been moms probably are laughing because you didn't too. Really giving them timely information. Also, that movie that's coming out, What to Expect When You're Expecting, will actually be talking about this program. So they've done some great outreach. Another program that has been really successful in the federal government is called Smoke-Free Text. And this is a program that was started by NIH, National Cancer Institute, to develop text messaging program as a smoking cessation intervention. It started as a program focused on teens. So they sent messages for those who are ready to quit smoking. You typed a message to them. It said up to 4 weeks before, it sent messages before you wanted to quit, before your quit date, telling you how to prepare, what to get ready for, what to expect, and then 6 weeks post-quit date. It's free with any unlimited text plan, or they can negotiate discounted, reduced messages if you have a limited texting plan. It also has messages that you can say, I've got a craving, etc. You type crave or type cheat, and it can send you messages. So let's say you went to a bar and you just couldn't help it and you had a drag. It'll send you messages to help you get back on track so you don't quit and don't have to start all over again. So really helping you move forward. It's got multi-platform dissemination, so it can do it by email now. It can do it by your iPad. It can do it by email or by GChat. And it can put reminders and content out to you. The program has actually expanded now to include also pregnant women. And here's an example of some messages. So there's an entire library that's developed and has an algorithm with a database of messages so that it taps which the algorithm is, where you are in your cycle in terms of quitting. If you've cheated in the last few weeks or you've craved, it can change those messages. And it can be adapted to specific contexts, for example, other languages or international, and it's free to download. So the intent on this point of the government was to make this a free resource that others could personalize, build off of, and augment in their own aspects. So it's basically what's called an open source solution, information that's free to the public. So if you're interested, it's smokefree.gov/ well, you just go there and you'll find, but the future plans are opt-in text messages, and as I mentioned, they just rolled out this past winter the smoking free for parents, for pregnant mothers. So really great messaging. Another program that has recently been launched is Text for Health. And this is a program focused at diabetes management. So as you see, you can enroll, and what happens is then it asks for a few questions to develop a risk profile. This would be questions such as your height and weight to determine your BMI, your age and gender, diabetes diagnosis, any family history, smoking status, things that would affect how likely you are to develop diabetes. And then it will categorize you as medium risk or low risk, medium risk, or high risk, and also your level of obesity. And then what happens is it starts sending you messages, goal setting and tracking messages, education and motivation messages, and local connections. And this is a government program. However, I've spoken to some other private sector programs that have built off this in terms of diabetes. One of my favorites is one that's targeted to adolescents who are terrible at managing their diabetes. It's hard to blame them. You know, they want to be active like their friends. So it's actually used intrinsic motivation. For example, if you track your diabetes and report it regularly, you get points towards free iTunes gift cards. You also have a nano pet on your computer. I don't know why that's appealing to me. I have a pet, and walking and feeding is a lot of work, but for some reason it's very, very attractive to adolescents. And for every time that you do well in terms of managing your hemoglobin A1C, your nano pet gets fed or watered. So you're responsible for taking care of your nano pet by taking care of your own health. So while this is a federal program, people have built off this program in terms of the private sector to really augment to different populations. And here's just a sample. Ooh, sorry, I forgot there's more. Here's a sample of some messages that are out there. One's a welcome message. Another one is talking about, eating slowly helps you manage and decide when you're full. Exercising, taking advantage of exercise. A new program I just learned about yesterday, focused on diabetes for children, can be personalized to your local community to tell you when fruit, produce is on sale at your local Safeway or Giant. It tells you the weather forecast, so it says today's going to be 90 degrees. Here's some fun activities you can do inside to keep cool but still be active. Same thing for snow. So really, a lot of people have built off these public platforms to personalize them to meet the needs of communities and private citizens. A program that I'm involved in with our organization, the Health Resources and Services Administration, is establishing a library of text messages for caregivers. So not just pediatricians, but also parents, babysitters, nannies, it could just be daycare workers, and it's focused on healthy eating for the population of 1 to 5. We picked this population because by the age of 5, hopefully most kids are enrolled in public schools, and there's outreach to public schools to help provide education to parents. But before this time, there's not a lot of guidance. After Text for Baby and parents age out, there's not a lot of guidance on how to stimulate your children to engage in healthy behavior. So what we did was we worked with the American Academy of Pediatrics, which puts out the Bright Futures guidelines, and we funded the development of messages, text-based messages, for children, both in English and Spanish, dictated to the parents to the child's age that people can automatically enroll in, that will be sent out to the parents. We tested it with focus groups of parents who thought it was great. Apparently, parents in the 20-year range, in their 20s, really find text messaging to be a quick way to get information. Easier than email, quickly accessible, short, a quick read. And so they really found this valuable. And here's an example of some of the messages, things about consistent meal times, or following children's cues instead of forcing the food on your child. When they're full, stop. It teaches your kids to use independence in terms of telling you when they're full. And autonomous behavior. So, giving them choices in foods rather than saying, this is what you'll eat. Giving them 2 healthy choices so that they can decide what they want. I wish I'd had this advice when I was a parent because my kids still ask for cookies for breakfast. So these are just some of the messages that will be out there. Our goal is to put these out in a public domain so they'll be free to programs to use. So rather than the government managing these messages, it'll be for programs to use to provide for free to parents. Just some other federal programs. There's a wide variety of federal engagement in mobile programs, and these are just a few of them. The first one in the upper left corner is from SAMHSA, the Substance Abuse and Mental Health Association, which is providing treatment locator for mental health clinics that can provide free or low-cost mental health services. This is one my organization puts out for community health centers. There are roughly 1,300 community health centers across the nation that provide free or low-cost services, serving over, I don't want to quote the number right now, but several million patients a year. I think it's 1.2 million per year, but I don't want to be quoted on that. So this is how to find a local health center if you're looking for health care. The My Foodopedia, which helps you measure food size and determine portion size. So you can actually take a picture of your food, and it'll tell you if it's the right portion size. Pillbox, which is developed, it provides rapid identification about which pill it is and the dosage. The EPA UV index tells you what the UV index is, where you're located. FEMA for emergency management. And then this is a program we're running, the Federal mHealth Collaborative, which I'm going to talk about. But so there's a million messages, everything from storm alerts from the federal government to diabetes assessment, smoking cessation programs I mentioned, locating health services, healthy eating and activities. So there's really a wealth of federal investment in mobile health. NIH is actually leading the way in a lot of that great work. So I'm just going to talk quickly about a federal partnership that's going on because I often hear people say the federal government doesn't see mobile health as a priority. And I want to just dispel that myth. This collaborative was established a little over a year ago now. We meet monthly. The purpose is actually closer to 2 years now. The purpose is information sharing and lessons learned. So we meet monthly. We often have presenters, both private and public entities, so we can hear about new innovations that are going on. We don't have a website because we won't want to be seen as endorsing any product. What we're trying to do is be educated about what's out in the field and what the new breakthroughs are in the technology. So we discuss recent federal activities. We collaborate, we share resources. This actually did start just as a Health and Human Services only, and then we had to seek White House permission because there was so much interest outside of Health and Human Services, so it grew. We currently have over 100 members from across the federal government on listservs. Here's just an example of some of the membership, so you'd be surprised at who's involved and how active and interested they are in their activities. On HRSA's website, if you go to hrsa.gov/mHealth, we have our own mHealth website right now where we list all the known federal activities in mobile health, so we encourage you to go there. It links to their website. If you know of a federal mHealth project that's not on there, we welcome it. We're trying to create a repository so people know what's out there and where to find that information. Some of the things that we have to consider as federal entrepreneurs, I would say, is the role of the government. So there's a clearly defined role between public and private partnerships. So, for example, with Text Your Baby, we have to update our memorandum of understanding. Who owns the data? How frequently we can update the information? Evaluation. The government wants to do this perfect, pure evaluation of technology, but technology is evolving. So, if NIH says this isn't a perfect evaluation, well, we don't want to slow down innovation also. So there's a very defined role that the government can play. The role of the government in terms of evaluation, message library. If we establish a library of messages, we want them to be free to the public. We don't want to, but others may be able to take those messages and personalize them and then make it a privatized program that has added value. So that's an issue that's still being worked out. So we don't want to stop the personalization and the development, but we also have to understand that there's costs for apps. And so if someone's going to use our messages in a pure, unadulterated form, there shouldn't be a cost associated with it. The message integrity. Can they be personalized, or are we compromising the integrity of the messages and what they're intended to do? Text for Tots, that program I talked about that's going to be for 1 to 5, is a perfect example. Those were developed with the American Academy of Pediatrics. If someone changes them, it's one thing to say your baby's a boy and personalize messages to be he should be eating these foods. It's another thing if someone changes how many fruits and vegetables a day, because then they're not following the guidelines. And lastly, sustainability. So the ongoing relevance of the program, we want to make sure it continues to have relevance to the public. What are the costs for maintaining the program, and make sure access is to low-cost and low-income communities, and thus the reason we've been focusing mainly on text messaging programs so far, but I think as the prevalence of smartphones increases, we'll be able to take more advanced focuses. So this is my contact information. Thank you so much. I'm happy to talk to anyone about federal efforts in health IT, and we'd love to hear from any of you that are doing innovative mobile health projects to share with other federal partners. Let me turn over to my colleagues now. Thank you.
All right.
Before Dr. Cohen comes up, I just want to do a data point, which is one of the reasons from a public health standpoint this work is so important is that if you look at the demography of mobile phone use in the United States, the largest consumers of all aspects of mobile use, text, voice, data, and video, are African Americans and Hispanics. And so it's the inverse of what you would actually believe. I mean, more wealthy, higher socioeconomic status, white folks, for example, have computers at home with broadband, they have computers in their office. If you're a carpenter, if you're a janitor, if you're somebody who has a job that doesn't require you to be using a broadband internet connection during the day, the way that you stay connected to the world is through a mobile device. And so one of the reasons from a public health standpoint this is so important is that you're reaching a universe that needs to be reached in a very efficient way. It's deeply personal to them. It's with them all the time, as you said, and it's integral to the way that they conduct themselves in their work lives, their family lives, and everything else. And so there's a great marriage here between the demography of mobile use in the U.S. and the public health urgency that you heard about here today. So just wanted to make sure everybody was which is why, by the way, the Medicaid was the highest,
exactly.
Right? Because that comports with, and why Medicare is the lowest, right? Because seniors are not moving along this adoption curve. Older white folk have use phones less than younger people of color in the U.S. So that comports exactly with the actual distribution of mobile use in the U.S. So it's,
and actually, adoption among homeless is very, very high. People often mistake that, but it's a great way to reach people who don't have an address in terms of their public health outreach.
or people that are very mobile and move around a lot. I mean, renters and anything else. Anyway, so Dr. Cohen, come on up. We've got your presentation up on the board, and this is your little thing. Thank you.
Well, I'd like to thank NDN for inviting me here this morning. I'm going to talk a little bit about mobile health issues from a perspective of both patients and providers, and just by the way of some disclosures about myself, I've got some research grants now, and I'm receiving funding from the McKesson Foundation for a study on text messaging in the emergency department, and we're also working on a project of diabetes management system, and I'm receiving some funding from the Air Force for that. So, broadly speaking, what's mobile health about? From my perspective, from a very broad perspective, it's kind of the application of all of the personalized health technology that's become available to health care issues. There are a variety of different platforms that mobile health has sort of been expressed on. Cell phones, and you've heard a lot about text messaging as one venue of that. I'm actually in a text messaging program right now as a subject. I got a text message this morning from a cancer prevention study, and it says, cancer study, did you know the risk for testicular cancer is greater in men whose brother or father has had the disease? Respond 1 for yes, 2 for no. Actually, I did know that, so I'll respond 1 for yes. But these have been coming in every day now for the last week or so. Smartphones and tablets as well have somewhat more capacity and display, and so we start to talk about different apps, and I'll show you a couple examples of those in a moment. And then finally we get to areas of dedicated devices. Some of these devices are freestanding and have their own wireless internet connectivity, and I'll show you one of those. Some of them transmit to a cell phone, for example, and actually I think David's going to have an example of that later this morning, and others sort of require some kind of periodic download. But these are all kind of different approaches that are being used in terms of implementing the technology at sort of the hardware level of things. So what can we say then about applications? Well, the first thing, and the thing that to me is actually the most interesting, is that in general I think these are very patient-centric applications, and they represent the type of patient empowerment, because in the end it's really the consumers who are going to be making decisions in this sphere as to whether they're going to be using these things or not. Another thing, and you've heard this already, and you'll see I think it is true, is that many of the patient-oriented applications, or broadly consumer-oriented applications, tend to focus on issues of health maintenance, not necessarily only disease-specific treatment. These are functioning in a real-time environment and provide the capacity for immediate feedback. In this, for example, in this text messaging, for me sending back, but also then for other systems to send further information to me, and for me as a provider to be getting immediate feedback from my patients in some circumstances. What sorts of things can these do in terms of problem or disease-specific applications? Well, we'll see some record-keeping issues, coaching issues, and in general, education and self-care directed issues. So what then are the potential benefits that these systems may have for providers and for patients? For providers, there's the potential for access to real-time a real-time clinical database from our patients, and for pattern analysis and recognition. For example, the diabetic patient who is in some way or other communicating back their blood glucose levels in some fashion provides me with the opportunity to perhaps provide some advice to them in the setting in which they're actually collecting this information and working from day to day. This can also provide me with clinical decision support, and potentially, depending on how strong the decision support software is that backs up these things, with the potential for adherence to evidence-based clinical guidelines and things like that, and getting back to issues of enhancing quality of care and working towards cost containment within the medical care system. Guidelines have an important role in terms of getting everybody kind of on the same page. For patients, there's potential to improve treatment and adherence. There's the possibility for frequent reinforcement. Rather than people coming in to see me every 3 months, they may be getting communications from me on a much more frequent basis. Educational resources, reminders, all are possible. So what then are some of the applications that we're seeing now? I've sort of broken them down into these groups, and this is by no means an exhaustive list. A lot of applications tend to focus on issues of personal fitness. Chronic disease management is another big area. There are programs out related to asthma. You've heard a little bit about diabetes, and I'll mention a little bit more. Congestive heart failure, hypertension, and I say more generally issues of medication compliance as a component of chronic disease care have been very important. Health education, the program the text message I got this morning is an example of health education. HIV/AIDS has been a very active area in terms of health education applications. You've heard a little bit about smoking cessation, another very active area. International health issues. This is a huge area in international health. And one of the interesting reasons for that is because in many of the developing countries of the world, it's oftentimes the mobile health data data transmission networks that are among the most technologically advanced components of infrastructure that some of the countries have, especially in countries where other communications channels, transportation channels, and such may be very, very primitive. And so people have looked for ways to kind of build on this infrastructure to encourage support. Clinical data collection. Laboratory modules, and again, you're going to hear about a very, very interesting laboratory module later this morning from David. Also, data transmission. Doctors can get patients' electrocardiograms, can get imaging studies and such sent through these networks. They're actually, as you'll see, both doctor and also patient-oriented imaging programs available. So this is one example of a application. I'll show you a little bit more about this in a moment that's used in diabetes. The patient can enter their blood glucose level on their cell phone, and it was, 122. They get a message back, perfect, your sugar is right where you aimed. The goal sugar for before breakfast is less than 130. So the patient's done something, gotten some immediate support back that is tailored to that very, very specific individual. Many of you may recognize this. This is, of course, Agent Maxwell Smart with the shoe phone. So this is perhaps the very first example of a smartphone. This is some data, and actually I think Simon was kind of alluding to this in terms of smartphone ownership in the United States. This is data that the Pew Research Center collected earlier this year on smartphone ownership in the United States, and overall about 46% of the country has what adults have a smartphone, fairly even distributions between men and women. As he mentioned, looking down at the bottom, actually, when we consider smartphone use in different important ethnic groups in the United States, it's pretty evenly distributed, and very importantly, with a very high rate of usage among minority communities. The age breakdown is also kind of interesting, and I think has implications in terms of healthcare. And as you can see, in general terms, smartphone ownership now is peaking in individuals, say, in their late teens through their 30s or so, but clearly is at a lower level in older individuals, those, say, 55 or 65. Now, to some extent, I mean, this certainly has implications for mobile health in that that's clearly a community that is a high consumer of healthcare resources. On the other hand, to some extent, this is a self-limited problem in the sense that we're all going to get older. Apps. Tim Cook last week said that there are now about 600,000 apps in the Apple Store, it is estimated that by this summer there will be something in the range of 13 to 15,000 health-related apps in the store. And what this is saying is that about 29% of people who download apps download an app that is in some way health-related. This is an app, actually there's a whole platform that debuted in the New Yorker several years ago, the MyPhone. The MyPhone, as you can see, actually already has some health-related apps. There's Fat Spec, Am I Fat? There is Shrink Calc, which is sort of related to health economics. So far, how much have I spent on therapy? And a variety of other apps that are particularly important to New Yorkers, such as App to Ask, when will I be able to afford a nicer apartment? Probably never. So this is a list I came across yesterday of the top 10 iPhone medical apps for 2011. There are a couple of things that are interesting about this list. The first is that they published it as the top 10 list, but there were 16 apps on it. But looking through the list, there are a couple of sort of general things that come out. First, you can see how many of these apps relate in some way to fitness and to diet. There's Muscle, which is a very interesting training app. It kind of has images of different muscle groups and specific exercises keyed to muscle groups. So in that sense, it's not just for general fitness training, but would also be very good in terms of rehabilitation and things like that. Nike Training Club, a fitness app. The Eatery enables people to take pictures of their food, and it then gets sent in, and everybody kind of votes it up or down, whether it's good for them or not. Fooducate, P90X, a fitness app. Fitness Club, Calorie Counter, Pregnancy. This is not the Text for Baby. This is a different pregnancy app. I don't know if they include any of the Text for Baby messages in this one or not. Gorilla Workout. Airstrip Cardiology is an EKG reader. Skeletal visualizes anatomy. It's kind of an interesting one both for medical students and for professionals. The mobile MIM is one of these image viewing apps for professionals, but interestingly, ViewMe is put out by the same company. It's an imaging viewing app targeted towards patients. So if patients have things that kind of want to know what it means and things like that. And so I'm just showing these to give you some idea of sort of what the consumers are what patients are interested in at this point. And again, it is fitness, it is education about health, about medicine, about these anatomy apps, things of that nature. And so let me just mention a little bit in terms of an area of my interest. How would we put this together, the capabilities in terms of, say, diabetes prevention? Where can we use things? Well, we've got education and information in the form of health education. Database access. For example, there are databases that are available that list the caloric and nutritional content of virtually everything available in any commercial restaurant in the United States. You could go in, plug in that you're going into Burger King or whatever, and know exactly what it is that you were going to be eating. So for people who are trying to follow structured meal plans, this is clearly helpful. Web access, training and coaching. We've seen the exercise programs and meal plannings. Games, as was mentioned, is a very popular approach, especially in adolescents and young adults. And I'll show you a small example of that in a moment. Rewards, diary functions, food consumption, exercise log. And finally, very interestingly, another area that we're seeing more and more of is communication with not just personal networks, but with sort of community of patients. So that, for example, in diabetes, we used to talk about diabetes support groups, and patients would get together once a month or whatever and trade stories. This has now become a virtual event, a virtual affair that can be done on a nationwide basis. And it enables, in ways that had not possibly been possible and whose potentials we frankly don't yet really know, to involve a community as a group in issues related to health care. Sensors is another area. I mean, so far we've just been talking about the what could be done in programs, but obviously the sensors are a big piece of this as well. Your phone itself has a lot of sensors that are sort of related to the environment. Position, altitude, there are accelerometers in your phone that enable it to determine how much activity you're on, light, dark cycle, temperature, and then we also have now a variety of what we could call physiologic sensors that are coming along. Vital signs, energy expenditure, sleep-wake cycle, blood glucose levels, oxygen levels, cardiogram, all of these are potentially available. The real question is, what are we doing with this data? How are we going to collect this data? How are we going to analyze it? What is the decision engine that is going to drive support decisions? That's, from my perspective, one of the areas where we're really going to be looking to see where the developments fall out over the next few years. This is an interesting one. This is a wireless blood glucose monitor, so somebody could check their blood glucose level, and it then goes sort of by a direct data line into a cloud-based storage system. It's available to the patient. It's available to their provider. It's available to whoever is appropriately connected within this environment. ZAMZ is another type of an interesting system. The ZAMZ is an activity monitor. It's that little green thing kind of that you can see in the little picture down in the corner there. But the point is, this is a whole activity program that is targeted towards adolescents, in which, depending on their activity level, they will accumulate various points, and as was mentioned, those points can then be turned into various reward-related prizes. Walk and play, this is one that I have. The iPhone actually has what are called accelerometers. It measures movement, and so the iPhone is itself actually an activity monitor, and there are programs that have come out that use the iPhone. So probably today has been a pretty low activity day for me because I've either been sitting or standing at home, but it's out there, and again, this is something that people are going to choose either to use or not. It's going to work for some people. It's not going to work for others. So what then, finally, are some of the caveats that we need to keep in mind at this point? As we've seen, the user base is currently limited in older age groups, although that is likely going to change. The kind of apps, many of which that I've been talking about, we don't really have any specific performance standards. I mean, there are a lot of consumer-based apps out there. One of my colleagues did an analysis year or two ago on smoking cessation-related apps and found that there was a great variability with the degree to which these apps conform with current treatment guidelines for the problem. And this is clearly an issue that is a very broad one in terms of what is going to be the regulatory role in confirming the advice that people may or providers may be getting for these systems, where, how much is that going to involve. There are a few long-term outcome or comparative outcome studies really showing the efficacy of mHealth in a real clinical setting. I'll show you one very shortly, but there aren't many out there. Clearly, there are privacy and data security concerns that are going to come up. We are, and this is, for example, if somebody is receiving text messages, text for baby, then that's, there's then information on their cell phone that individual is pregnant. Is that something that, if that cell phone gets lost, is that something that person is concerned about or not? So the extension of these clearly will raise security issues. Another issue that I've been spending a lot of time on the last 2 years now is the need for integration with health record networks, a problem which I could spend another hour talking about, and so I won't, except to say that we don't want these systems to be functioning independently. Ideally, as you'll see, we want these systems part of broader healthcare networks, but we have to figure out how to deal with the connectivity issues, how to deal with the language issues, how to deal with the fact that these programs and these approaches have very, very different focuses. And finally, we really, in a lot of ways, we don't yet know what works in this whole sphere. And again, that relates to the long-term outcome studies. So this is just an example of one. This is the WellDoc Diabetes Manager System, and this was actually a true clinical trial, a one-year controlled randomized clinical trial in which some patients received this WellDoc Diabetes Manager System and others did not. The hemoglobin A1C is a measure of blood glucose control. It is kind of the standard test that is used in this area to assess the benefit of treatment, and our goal is to keep A1Cs down, to lower A1Cs. And so what you can see here is that by the end of the 12-month trial, there was, in fact, the red are the patients who were using the WellDoc Diabetes Manager System, and they had, in fact, achieved and maintained A1Cs that were significantly lower than that in the control group. And just to give you an idea, I mean, the difference in those A1Cs, which was about 0.8 to 1.2% in the A1C level, that's comparable to what a medication would do. I mean, that's comparable to taking that control group of patients and adding an additional medication to what they are taking now. So the clinical effect here was not trivial. It was indeed a significant effect. And we need more studies like this showing that indeed these effects are achievable. So what then are the opportunities? That mHealth now has? Well, there is, as we've seen, increasing penetrance of smartphone usage. These things are very much patient-oriented and can be personable. These are very scalable devices. As you know, what's the current numbers on Text for Baby? You said it was several hundred thousand women. So you know, as we all know, you text one person, you text 1 million people. It's the same thing. So scalability, expanding capabilities of devices and data networks, and what has actually now become a very, very broad mHealth community, which involves researchers, both traditional healthcare researchers as well as those in other allied areas, providers and payer organizations, the telecom and IT industry, startup entrepreneurs, app developers, NGOs, government and non-government, government, healthcare and research agencies. The mHealth community over the last few years is really expanding, and the fun part of this is that it's a very, very open community now, and everybody is interested in talking with one another and researching, and I think that is where a lot of the dynamic and the energy is going to come from. And so ideally what we are going to see with further development of mHealth are these kinds of patient-centered integrated healthcare networks. And finally, and as I think Simon alluded to, you know, the thing about mHealth is it's not a pill, it's not a treatment, it's not something where your doctor is going to say, download this app and do it for the next 2 weeks. Rather, it is a set of tools, and our job now is really to find out which are the tools that are most effective in which situation, and which are the tools that you know, need to be tweaked and that we need to move on. And so with that, I'd like to thank you again for your attention here this morning, and I'm going to turn things, I guess, back over to Simon.
All right. Good morning, and thank you. And this is all very interesting. We all, you know, healthcare is such a huge industry and impacts us in so many different ways. We all have sort of a different looking glass at this, right? And when I think about SMS and texting, I think about it as the way that I can get my kids to respond to me, because they don't respond any other way. But yet there's real you know, value here. So I'm with Nanomics, and we're a young startup company based in the Bay Area, and what we're focused on is the development of what I call a mobile diagnostic platform. And so what you've heard so far is really a discussion about information management, patient management, education. And where we are is we're back at the very beginning of this. I'm sick. something's wrong, I need a diagnosis, okay? And so we're at that very beginning, the underpinning of the healthcare system, which is the time that you take and you start to say, what is it that I have? What's my condition? Whether it's an A1C measurement or, as I'll talk about here, diagnosis of heart attack. I'm going the wrong way. There we go. So when you go to that blood draw facility and you have your blood taken, it gets taken and put into a tube and it gets sent off generally to a very large laboratory which is full of very expensive people and very expensive equipment, and hundreds of thousands of dollars, if not a lot more than that, involved in that whole process, and it takes hours or sometimes days, depending on what it is that you're trying to figure out, okay? And so that's sort of the basis, sort of the first level of healthcare and health diagnosis. There have been now the development of some point-of-care devices and systems which are faster and less expensive, but yet they're still, they're not as good, they're not as accurate as these large laboratories. So what Nanomics is doing is building a system, a detection system, which has the ability to be extraordinarily fast and accurate, but also to do it in a way that provides you with an answer that has the same quality that you'd expect if you sent it off to this lab of hundreds of thousands of dollars of infrastructure. And the whole idea here is timeliness and improving the available information that the patient and the doctor have to deal with their health care. So I think about point of care as increasing the proximity of the decision making, not only in terms of time, but also in terms of closeness. If you can, as a physician, if you can have your patient, you can have them and you know what the answer is, you can do the therapeutic that you're needing to do, you can take the action that you need, it's much more effective. If I send you home and I call you in 2 days with an answer, it's much less effective. So what we're doing is developing systems that can be used, whether it's in hospitals and emergency departments, urgent care clinics. We talked earlier this morning about physician office laboratories, and eventually this technology will go to the home as well. For us, there are really 3 elements that drive this. The first is critical care decision making. I have a problem, I need to know the answer now, okay? And so I have an emergency medical situation. I don't want to wait an hour for this sample to be sent to the lab and the lab to send me back an answer, because I need to know what that is, okay? The second area here that we're very interested in is patient management. Patient management runs the gamut from, I have the patient, I want to know that I should give them antibiotics, I shouldn't give them antibiotics, or I have the patient and I can talk to them now about their therapies and their treatment courses. It's a real problem here for things like HIV and HIV testing and management. Patients will show up, they'll get the test, but the demographics of most of those kinds of people make it very difficult to eventually get a hold of them and tell them what the answer is. So you want to have these things for patient management's sake right there at the time that you have it. You could also extend this patient management to some of the things that we've talked about earlier here about monitoring the outcomes and monitoring the information that you have for in a home kind of situation. And then finally, the third area is constrained resource settings. We have a lot of those in the United States. We have a lot of urban areas that don't have all of the health infrastructure that they need. We have remote areas in the United States where there aren't really good health care. In China, for example, where I spend a lot of my time, you have sort of tier 1 cities that have hospitals that look like ours, but yet if you go a little ways outside of that, you have virtually nothing, okay? And there's a Chinese government program right now to build 80,000 clinics to service these areas outside of their major metropolitan areas. Now, if you think about 80,000 clinics, or you think about a rural clinic in Montana, are you going to be able to afford to build a laboratory and equip it with with equipment that costs hundreds of thousands of dollars and people who have to be medically trained and proficient in the operation of that? And the answer is no. Okay. So what we've done is we've attacked this whole area using a carbon nanotube-based technology to provide an electronic sensor environment. So the idea here is carbon nanotubes, very small, elements which are, highly electronically conductive. And it provides us a sensor where we're able to build that sensor into a product that we have here, and I'll talk about this in a little bit. This is the first product, which is effectively a clinical lab system. This is the hundreds of thousands of dollars clinical lab system. It'll provide an answer for tests that are run on it. In the case of a heart attack here, we'll provide that answer in less than 10 minutes, okay, and at a cost of less than $1,000, okay? Now, what it doesn't do that the clinical lab is really good at, okay, is it doesn't do thousands of samples in big batch processing. So this is not going to replace the clinical lab, but what it's going to do is extend the clinical lab capabilities to reach out into these situations where more timeliness and more, effectiveness is a good thing. Now we also have this. Now when you operate this, it'll also operate with a fundamental. There's an app for a smartphone where you can take and you can operate the system. You can scan a patient ID. You can scan a product ID so you know what you're doing. You can trigger the running of the assay, and you can get your results back. Can come onto this phone, or it can be emailed, or it can be sent to the cloud to a data storage. So you can either use it locally, or you can use it in a mobile-enabled, kind of fashion. Now, the key to this is, and this is really very, very simple to use. There's I have these. These are not packaged final products, but if you imagine, put a glossy cover around this for a second, okay? You take a whole blood sample, okay, which you can get out of a finger stick, an aggressive finger stick as we talked about today, or you can get out of a blood draw, which is done by many paramedics. You put that into this cartridge. There's a little transfer, and you put that into this cartridge. You put the cartridge into the reader. The reader says, do you want to start the assay, yes or no? You want to start it, you press yes. You can press yes on the cell phone as well. That's the last thing you have to do to operate this system, okay? Put a little bit of blood in here, put it in. You want to go, press this round button, go. You have your answer in 10 minutes, okay? And so it's extraordinarily easy to use. It's very cost effective. The cartridges utilize, and again, they're very cost effective because the heart of this cartridge, and I think I have this on the next page here. The heart of this cartridge is a biosensor, which is made out of the same materials that are used for a glucose strip monitor. There's billions of these made by manufacturers. And so what we've done is we've captured the economies of scale of that manufacturing process. We've upgraded it and designed, as you can see here, a very sophisticated biosensor, which can be made literally for cents, okay? And it does, this particular design you have here does 4 assays related to a particular cardiac condition, okay? So that is the basic fundamental, innovation that we have done, which is to figure out how to use carbon nanotubes in this very small, cost-effective footprint to provide a very high-quality resolution, very high-quality signal in a very fast process. Now that gets put, if we want to talk about how, the plumbing, then there's a thing called microfluidics, and the plumbing is what makes this cartridge. Think about this as a series of credit cards that are stacked up with various cutouts in each of the credit cards, and it forms a bunch of channels and vias that are in here. And so you can take the blood and it actually goes through, it converts the blood into plasma. It takes and it puts it down into the, into the detection well, and it accumulates all of the waste that's here at the same time. So what you have is a fully integrated biodisposable unit. So you don't have to worry if you're dealing with HIV or you're dealing with malaria or Ebola virus or those kinds of things. You don't have to worry about the contamination. It's all in here, and the system itself is reusable without concern about contamination. And then the reader is very integral to this. The cartridge does basically all of the wet biologics. The reader does all of the mechanics. And so it's a highly sensitive electronic device, and it includes pumps and valves that are necessary to drive the fluidics through this microfluidics channel. And again, it has Bluetooth connectivity today. My plan is the next generation of this will actually embed its cell phone inside of this, so you'll have the mobile technology right here. And you can think about it, if you're in a rural setting now and you've got a medical situation, you run the test, you have the data, you bang it to the cloud, and you've got somebody like our friend the doctor here sitting back in Washington, D.C., looks at the answer and goes, okay, well, this is the problem, and back goes the instruction to the less skilled persons. This is designed to be very easily used by non-skilled medical personnel, but yet provide the same capability that you'd have if you were in a clinical setting. And so the first product that we're doing here is related to the emergency vehicle, the paramedic diagnosing somebody with a suspected heart attack. And it measures 4 important attributes here. And the whole idea is in a heart attack situation, time is critical. Time equals muscle. The longer it takes to get at this, the greater the deterioration of the heart and the heart condition. So what we're aiming to do is today, if you look at it, and this varies a lot by the healthcare unit that you're in, if you are experiencing symptoms of a heart attack, the ambulance comes, takes your history, probably runs an EKG. More than 60% of ambulances run EKGs now. I was surprised to find that out. Okay, decides you need to be transported to an emergency department. You come to the emergency department, they take the blood, okay, and the blood then goes to the lab, gets tested, comes back. If you have a positive, you're at that point ready to go to the cath lab or make whatever interventional move that you need to make. And that's about a 90-minute kind of process. It can be a little bit faster than that. It can be a lot longer than that depending on the situation that you're in. What we're trying to do then is to get that decision point moved up so that at the time that the ambulance would run an EKG, they also take the blood sample, put it into the cartridge, get the answer in 10 minutes. So when they arrive at the emergency department, they have the answer, they know what to do. This is very important not only for treatment of the patient, but it's also important for utilization of the emergency department. You may decide you have a patient that you want to just hold and watch for a while. And so it's very important on both sides, the positive indication as well as the negative indication, because release of patients, the faster you can release them, the less money you're going to spend. And so what we see is the ability to diagnose these conditions earlier. 30 minutes faster diagnosis relates to a 1/3 improvement in patient mortality in a heart attack situation. This is a huge return. Okay? You also can save a couple of hours on release when you get around to saying, well, this person really doesn't have a heart attack. You can get them out of the emergency department a lot faster. That also has a huge savings for the facility. So this is the first product that's going into clinical trials in San Francisco here. We just got IRB approval. We'll be starting that within the next couple of weeks. And we're very, very excited about it. How does it rate and how does it relate for the technical people? This is a comparison to a central lab study using reagents and controls from a central lab. Basically what this says is that this product operates right on top of the central lab. There's an R squared here of 98.98, which means that it's 98% correlated to the results. So this works, it's fast, and it's accurate, and it's equivalent to what you can get out of a central lab. You get this in 10 minutes or less, depending on the indication. Now, that's one product. This is a platform, okay? And we're going to take this and we're going to be able to bring this across a whole lot of different areas. For instance, in the blue area here, you have other critical emergency kinds of situations. You have, you know, we talk congestive heart failure, for example, shortness of breath. Somebody shows up with shortness of breath, you know, it's not a heart attack. What is it? Is it an asthma attack? Is it, congestive heart failure? One of those kinds of things. So we'll definitely be working in that area. Emergency medicine also, traumatic brain injury. Your child, you know, falls off a bicycle, hits their head. What do I do? It's one of the hardest problems in emergency medicine today. The government has a very large interest in this for traumatic brain injury for soldiers in an exploded device kind of scenario. Stroke also is a possibility here. These are limited, probably more right now by getting the exact markers right than they are by the technology. It also has a great deal of applicability to infectious disease, influenza or viral infections, any of those kinds of infections. So this will get taken across a whole wide variety of indications for use. Okay, that's it. Thank you.
We have 10 minutes, so we can bring my panelists up. We're going to take a couple quick questions with the audience. I want to thank our three wonderful experts. Thank all of you for your patience, sitting through all this. The good news is this will be on the web, so people who weren't here today can watch all of that. Hopefully, we can get your PowerPoints too, that we can put up in addition to that. Let's just get to a couple quick. Why don't we ask 3 or 4 quickly, and then we'll just answer them all together in one question. Yes, sir. And yes, ma'am.
We were going to take the topic technology we were going to. One of the things I've seen you mentioned about the mobile in the dark communities, and even in the rural, that's been part of a lot about what we know. It's been remarkable in the sense that the technology divide has been ended because of mobility. One of the things I've talked to folks with Health 2.0 folks and a lot of the providers is that how does this stuff work with people in real time? Because I think what you see is, because they post it, oh, it's a generational thing. But it's also a thing of comfort level. How does this work for me? Because I think a lot of stuff is very good, but at the end of the day, how does it work for real folks? How do they make it work for themselves? And I think that's going to be the biggest issue among all, because people are very afraid of technology, anything new. So can you kind of address that, especially to people who start up and all you guys sort of touched on that. How does it make it easier?
Yes.
First of all, I have to say, I don't think people are afraid of technology. Young people are not afraid of technology. They love technology.
Well, I said older folks, not young
I'm
people.
afraid of
Yeah,
technology.
older folks. Yeah, I said young people.
I'm interested in outcome measures. And, for example, I would like to know if the Text for Baby, is that what it's called? If there have been the outcome studies, and what the measurements might be. And I looked at your diabetes chart, I wasn't impressed. I thought the 2 endpoints, the control group and the treatment, or called the treatment group, their error bars overlap.
No, there was statistical significance.
Okay, but and your treatment group started out worse. They weren't well matched. They were patients who were very big.
Doctor, we'll let you get to that in a second. And then anything, and then, yeah, sir, did you have a question as well? No, William.
No.
Wait, William, yeah.
I think what we really are seeing is this, we have an ability now to treat disease for a very long period of time and keep people alive. That's what's changed in the healthcare system in the past 25 years. What you're really looking at is how do you enable a patient to have a disease for 25 years and actually maintain their health for a long time. We've never done that in human history. We're trying to create that now. I think
one last question, and then we'll let our panelists jump in here.
Dr. Harris, you mentioned that it's a priority to get mobile into meaningful use, and I was wondering if you could give us a preview of what stage in that process you see that happening, and what some of the obstacles are.
So Dr. Harris, why don't you start, and we'll just address any of the things that just came up. Yeah.
First of all, it's my priority, not necessarily the administration's priority. So personally, I would invest in insurance. I don't think I'm the only one, but it's the thing I'm working on. I think there's an agreement that there's a plethora of remote devices, mobile health just being one of them, and that information's out there, as my colleague pointed out. And to get that information integrated so that it can help decision makers make decisions. I think I would like to see stage 3 meaningful use actually incorporate that. As I mentioned, stage 2 is going to bring in, or was proposed to bring in patient portals and secure messaging. So there's more of an engagement of patients. So I think that sets the stage nicely for stage 3, which originally the outline proposed would be remote devices interacting. I don't know if that'll include mobile health. I'm pushing towards that. There's a number of barriers. One is standards. Another one is privacy and security, as has been mentioned, and there's an entire, the Office of National Court just announced a big study to look at privacy and security and how it relates to mobile health. I think privacy and security, it's still an issue, but it becomes less with younger generations in that there's less of a fear factor. So that gets to your point in terms of the information. But there's other issues in terms of, there's a multitude of devices out there, so how do we determine which ones are allowed? So there's needs for standards around that, for the interoperability, but also FDA's got a rule about, or they're working on coming out with a guidance on mobile devices. Their goal is not to prohibit mobile devices, it's to make sure that when mobile devices come out, they actually do what they say they're going to do, so protecting the consumer. My friend is up to date, would like to be as hands-off as possible, but he wants to make sure that the devices are accurate, do what they do, don't tell you, you have one condition, you go out and treat it, and you don't, for example. That's just an example of that. So there's a number of issues out there. Another issue that is the issue of regulations. People need to be licensed in the state in which they are. So for example, let's say you're using a mobile health device to, it's one thing to get text messaging, it's generic messaging based on clinical data. It's another thing, let's say you're using a mobile phone to talk with your doctor. Your doctor cannot be talking to you and prescribing medication outside of state grounds because he's only licensed in the state you're in. So if you move to another state, there's an issue there. So there's there's a number of policy barriers that federal stakeholders are involved in trying to address, but that are going to have to come into play and be addressed over the time being. As far as you're concerned about mobile devices, I agree. I think it's really reducing the barrier. I think there's still a lot of barriers in rural areas in terms of broadband capability and access, especially since it's not integrated into an electronic health record. And so unless the consumer is sharing their information with providers, there's no integration of information. But allowing the consumer to do that allows for some sort of integration. As far as the older generation barriers, my focus is, my background's in gerontology, or geriatrics, I'm not a clinician. That's always been a passion and interest of mine. I really think there's more acceptance of it when it's wireless, if that makes sense. So when it's not using a phone and getting text messages, but it's more that there's a device in my house that feeds in my weight on my scale. Or I know how to check my blood glucose, it's automatically wireless connected to my doctor. So I really think the acceptance of technology when it's invisible is very accepted by seniors, and I think that'll become the wave of the future. I also think with the aging of the population, when you look at 55 to 65-year-olds, there's more penetration. So right now we're trying to put a Band-Aid on a problem that will age itself out. I don't disagree that the problem's there, and I'd like to address it. Some of the things I'm working on, in fact, I got an email this morning, is working with the Administration on Aging on issues about how do we engage seniors in healthcare, whether it's through using senior centers to educate them on computers and the internet, to whether we provide guidance on what the future of healthcare holds and what it means. So there's a lot of efforts to update and educate and break that fear down, but it does exist, and it's a barrier we have to overcome. I apologize, I can't recall your question.
My question was about how do we use these technologies to change behavior, because ultimately, if we don't change behavior, we don't get that health outcomes at lower cost. It's not necessarily.
Absolutely, absolutely. And so that's an issue of both the current funding mechanism in the United States of America. And as I said, I can't speak to that, but I do think these innovative models coming out of CMS are looking at new models for reimbursement, and there's going to need to be a way to integrate But, you know, there's going to be more of that using mobile devices. Aetna just bought iTriage, which is a mobile app. There's going to be more of this integration of insurers using devices and then motivating the consumer through that. And some of the external intrinsic motivating factors that have been identified are probably going to help engage consumers more. But there's not enough studies out there to know what works and what doesn't. For Text for Baby, there was a small-scale study in San Diego that showed that it was very effective among Latino women. But there's a number of studies going on there. The best one is the Department of Defense is doing a pre- and post-study, so a longitudinal study. I wish I had those resources where I really look those results. Within the federal government, we merged resources from CDC, CMS, my agency, HRSA, and I forgot, I don't want to discredit other agencies, but a number of health and human services agencies to fund a study with Mathematica Policy Research. We are looking at a number of factors. First, where we're talking to people, did you take the messages? What do you think of the messages? Were they acceptable? Were they reasonable? Two, did it change your behavior, et cetera? And then working within community health centers to look at their electronic health records and say, did these women actually, were they less likely to have a preterm birth, et cetera? We can't look at the long-term outcomes. It would take too many years to do that. But the federal government has barriers in that we have something called the Paperwork Reduction Act. That alone took about 9 months to get clearance on our surveys. So again, it's that toss-up. You want real-time results in real time. And if you look at the NIH criteria for a study, you know, you've got this hold-up. And meanwhile, they've been integrating and evolving their model where they're now asking consumers direct questions about whether their message has been useful, have they gotten the flu shot. So they're redesigning their programs as they go along, which is great, but it affects our evaluation because the program is not identical anymore. So it's something to be taken into consideration, and that's something the government is trying to forge with, is we want results, but if we look at the scientific integrity to get published in a peer-reviewed journal, we impede the program from being proactive and thinking forward.
Great, Dr. Cohen.
Well, I think that the theme of a lot of the questions that I've heard relates back to one of the things I mentioned earlier on, which are issues of patient empowerment. And I think that relates to outcomes and to study design and other issues as well. I think one of the things that's really unique about the mHealth technologies compared to a lot of other things in sort of the traditional health development venue is the degree to which patients, consumers, non-professionals are already very deeply involved in decision-making in terms of what's going to go forward. I mean, think about it, you know, compare this with, say, you know, this was big pharma that was developing a new drug. So, you know, there'd be some laboratory professionals that would be working, and then it would go through some clinical testing, and then, you know, how would they do the clinical testing? Well, you know, there's, as you're aware, I mean, they frequently involve what's called control groups to get a placebo. Well, you know, what's the placebo here? I mean, think about how the issues in terms of designing an outcome study in mHealth. It's a very, very different issue. And we're really still wrestling with a lot of these issues in terms of how do we design? What should our, you know, appropriate markers be? So I think that there's a very broad agreement here that we need more, you know, that in the end, this is going to have to prove itself. It's going to have to prove itself sort of scientifically in terms of hard outcomes, and it's going to have to prove itself in a marketplace of consumer choice. Is this something that people in the end choose to use? Because it is going to be very voluntary. Again, I'm, you know, not going to be questioning my patient. Did you check your apps, you know, 3 times? I mean, this is something that will only work if we, you know, if we keep that in mind very early on, that we need to be focused on the patients as being intimately involved and empowered by these systems. In reference to the study, we can talk a little bit more about it later. It actually was not my study. I'm only showing that as an example of how we are now starting to see that these studies are indeed coming out. And I'm very hopeful that, you know, over the next 1 year, 2 years, you know, short time frames, that we will indeed, you know, this will be a major focus of the area, because it's clearly a weakness. That what works in terms of mHealth, I don't know yet. I mean, I've got some
Yeah, I think from my standpoint, you know, we're really leveraging the mobile infrastructure to speed the time to diagnosis and to try to improve, you know, patient outcomes through that level. And I think we've done a fair amount of outreach to paramedics and also to emergency room physicians, and we've found an extremely strong desire to have these kinds of tools available. So I have been in other areas where physician reluctance to new ideas has been a problem. This does not seem to be one. I think universally, caregivers, first responders, emergency docs understand that time is a really critical element here. So we're getting a lot of buy-in on what we're doing.
So two final thoughts, just because I know our panelists have to go. One is that, you know, we, at some point in the next 5, 6, 7, 8 years, maybe 10 years, everybody in the world is going to have a mobile device, right? We'll be at 90, 94, 95% penetration. We're in the 70s now globally. And it will be a tipping point in human history. There is no doubt in my mind that if you look at the experience of the West, that when we had this radical democratization of information that came about through the development of the printing press, that what followed that was the Enlightenment and the Renaissance, right? That there was this extraordinary outpouring of human activity and human ingenuity that changed, you know, the course of history. The question that all of you have to think about, and I'll drill it down to David's point here in a second, is that if we're about to hit this point where everybody has one of these, because there won't be a thing called a smartphone, right? I mean, it's just a mobile device that, because they'll all be smart, there won't be a voice-only option in a very short period of time. I mean, the entry point of every mobile device will be like an iPhone from 3 years ago very soon. The data networks are there. It's the technology possible. It's going to get there. Vodafone is certainly pushing this, the envelope on this. Is that, you know, what does it mean that everybody's going to be connected, that everyone's going to have access to this global communications network, that everything will be flowing through it? And so the whole point is that my prediction is 10 years from now, this conference where we bring the three of them back together, the idea of mHealth will be sort of an antiquated notion. There won't be a ability to think of healthcare delivered in any place in the world that won't be running over mobile platforms, because everything we do is going to be running over mobile platforms. Commerce, the way we communicate with our kids, the way that my son watches, you know, the 3-minute summary of the Nats game, you know, when he gets up in the morning, right, on my iPad, right? It won't be any human activity that won't be centrally running over these, you know, mobile networks. And what's exciting about this, right, is that the capacity for collaboration, for learning, for universal advancement. I mean, one of the things that David is, you know, I run around with David around town, we're meeting at BARDA and other places, is that, you know, we have the ability now to imagine that 10 years from now that this kind of remote diagnostic tool will be everywhere in the world. And that for a world that right now you only have, let's say 15, 20% of the people alive have the ability to get quick, reasonable diagnostic capacity as a core part of healthcare, and that healthcare is happening in most of the world without diagnostic capacity, right? I mean, think about this, right? I mean, it's like not having electricity. It's not, that within 10 years, that's going to be solved. I mean, it's unbelievable the impact that that's going to have on public health outcomes and costs throughout the entire world. So we're at a point where, you know, we're still, I think all of you are correct. We're still developing the language around this. We still don't really understand how it's going to work. But what we do know, and to me, when I'm listening to them, the other big takeaway I had was the way we think of healthcare in the U.S. now is that it's an extraordinary thing. It's something that happens in extraordinary circumstances, right? You're sick, you get in an accident. You know, it's something that is not common and routine. It's not usual and habitual. It's not something that happens every day. The big change is that our interaction with the healthcare system is going to become every day. It's going to become common and routine. And it's a complete inversion of the entire you know, the way that we reimburse, right? The entire healthcare system is built on a model of extraordinary intervention, and yet it has to now invert itself and become something that's common and routine. These tools allow that to happen in a way that's cost effective. And in my mind, there is no question that there are going to, and I'm a technology evangelist, right? But there's going to be dramatic, rapid, and extraordinary health outcomes that are going to happen very quickly and it's going to also drive down costs, right? Things can happen, but part of what we've got to work on, my job at NDN, is to clear away the policy and regulatory hurdles from the outside to create an understanding of what government can do to accelerate all this. And working with some of the people in this room, I hope we can make a big difference in that in the years to come. Thank you all very much for coming. This was a terrific panel. You guys were great. Let's do this again, and let us know how we can help all of you. Thanks, everybody, very much.
Thank you.